So good morning. Welcome to another segment or episode of Fertility Speak, Conversations with Experts. I'm Dr. Daniel Stein, a senior partner of Reproductive Medicine Associates, or RMA of New York, one of the nation's premier and most respected fertility practices. I have over 27 years of experience as a reproductive endocrinologist or fertility specialist in New York City, and I'm proud that my partners, associates, and myself have helped many thousands of couples to achieve parenthood. Today, I'm very pleased and honored to speak with Dr. Phil Romanski, one of New York's rising stars in the world of fertility care. Dr. Romanski is an accomplished physician and researcher and continues to contribute much to the world literature regarding fertility and fertility care. This segment of Fertility Speak is called Infertility in Woman's Age. What do we know and what can we do about it? So we will address, by the way, the effects of paternal age, of the man's age, in a future segment with Dr. Natan Bar-Chama, who is an expert in reproductive urology. So again, welcome, Dr. Romanski. Thank you so much for joining us today.
Thank you for having me.
Absolutely. So, Dr. Romanski, we know, and women know in general, that as they age, there is a lower chance of conceiving in any menstrual cycle. And we also know that a woman's number of eggs declines over time, and that the quality of those eggs also may diminish over time. When in a woman's lifetime does this occur? When do we expect to see these big declines? And at what stage does a woman say, okay, well, I need to be very focused, not worried, but focused on getting pregnant?
Oh, it's a great question. I often think about the function of the ovary in two separate ways. I think about the quantity, the number of the eggs that a patient has, and I think about the quality of those particular eggs. We know that both of these parameters are changing and declining over time, but they happen independently of each other and at different time points. So the way that the ovary works is after a patient is born, it stops producing new eggs. It doesn't generate any more new eggs, which is different from how the testicle works. The testicle is constantly producing new sperm cells. So what happens is each month, a patient loses a few hundred eggs from that ovary. And so from the time of birth, really, in puberty on, there's a gradual decline in the number of eggs remaining. I think it's important for patients to understand that the number of eggs is not really associated with fertility. It's more a predictor of their reproductive lifespan.
So that's a very good point. So when we talk about this and we talk about age, and women often hear this term ovarian reserve, their supply of eggs. And that's something they're always coming here and they'll say, well, I want to do this test or that test to determine ovarian reserve. What does ovarian reserve mean?
The ovarian reserve is a couple different measures that we take that estimate the number of eggs that are remaining within the ovary. We use it as reproductive endocrinologists to really help predict how a patient might respond to ovarian stimulation for a patient that's maybe doing egg freezing or IVF treatment. So it really helps us to, number one, tailor the protocol to that specific patient to optimize their outcome. And number two, to counsel the patient on what their expected egg yield might be from a single cycle.
Okay, perfect. So when a woman is still in her mother's womb, when a female is still in her mother's uterus, and it's about 20 weeks of gestation, she may have about 7 million eggs. What happens by the time she reaches birth, and then by the time she reaches puberty?
So from halfway through gestation to the time of birth, there's a pretty significant reduction in the number of eggs. There's around 1 million eggs remaining. By the time somebody reaches puberty, that's reduced further to about 100,000 eggs remaining at that point. And then we see a few hundred eggs that are lost each and every month from there on until the time of menopause, when there's essentially no eggs remaining at that point.
Yeah, or perhaps there are eggs, right? So we do know that if you were to look in the ovaries of a menopausal woman, there might still be 1,000 eggs.
Might be about 1,000, exactly.
Right, but they're not necessarily functional and not necessarily leading to a pregnancy. And that actually leads to a very important question, which is that there's this belief among many women and men, both, that as long as a woman is ovulating, as long as she's getting regular menstrual cycles, that she's still going to be able to get pregnant. It doesn't really matter about the age. It's about whether she still has eggs, whether she's still ovulating. Is that a true statement?
So that's not a true statement, and this gets back to that other point about egg quality, or egg quality, the quality of the eggs within the ovary itself. I think it is a common misconception. I commonly see patients in their late 30s, early 40s who are very active, have always led very healthy lifestyles, and they're usually surprised to understand that the quality of their eggs is not as good as they might have thought. And this is the biology of the ovary and of the follicular unit. Unfortunately, it's not related to overall physical health. While those things are important for a patient, when they do achieve a pregnancy, it's going to make that a much healthier, happier pregnancy. It unfortunately does not reverse or delay the quality decline that we see for the eggs.
Right, right, and that's an excellent point. That's an excellent point, and it is very important to emphasize that age is very, very important in this factor, because ultimately a woman could be getting very regular menstrual cycles when she's 45, 46, 47, but many times is not getting pregnant because the quality of the eggs changes. And actually now let's go a little bit slightly more scientifically. When it comes to the eggs themselves, or to the embryos that are created from those eggs, if we were to look at the embryos of a woman who is 40, for example, versus a woman who is 30, so a pretty big age difference, what might we expect to see in the embryos, or how might we characterize the embryos of somebody who is 40 compared to somebody who's 30? A little bit more from the scientific standpoint, just for the general viewers to understand.
Yeah, of course. So when we look at a cohort of embryos from a patient in their young 30s, if we were to biopsy those embryos to evaluate the genetic components of the embryo, we would see in a younger patient, about 2/3 of those embryos are going to be chromosomally normal. And we see about 1/3 of those as being abnormal. As age increases, we see that ratio start to shift. And that's largely driven by the quality of the egg. And the way that I generally explain it is that the eggs themselves, again, they've been there since before birth. And while they're very stable in their quality for the first few decades of life, they are just single cells and they're somewhat fragile. And as an egg matures prior to ovulation, there's a process that happens with the DNA where it duplicates and then separates. And what we see is that as time goes on into a woman's 30s and 40s, the apparatus, the components that are involved in that process, they're less efficient. They don't work quite as well. And so the DNA doesn't separate in the normal fashion. And sometimes you get extra DNA or missing pieces of DNA in that particular egg. And then when that egg is fertilized, you then end up with a chromosomally abnormal embryo. So that in the late 30s, we see about half of embryos might be chromosomally normal. And by the time a woman is getting into their 40s, we see that reduce even further to about 1/3. And then eventually you may see in around age 42, 43, only about 10 to 15% of embryos as being chromosomally normal.
It is fascinating. Of course, yeah, chromosomal abnormalities are extremely important. DNA mutations occur also with time. There are changes even in the mitochondrial function of eggs and embryos as time goes on, which affects the energy supply essentially to the eggs to allow them to undergo proper development and for embryos to divide. All those things do happen. But besides the eggs themselves, if we were to give, for example, young eggs to a woman who is maybe a little bit older and doesn't have a good egg supply, are there any other effects of age? So, for example, is it just related to the eggs? Can I then take somebody who is 45 years old and say, here's the eggs of a 20-year-old, and let's see if you get pregnant? We know we do this all the time. We do egg donation. But what other factors are there about age that you would say to a woman, let's try to get you pregnant earlier in life rather than later in life?
Yeah, this is a good question, because while success rates are largely driven by the egg, there's other components that are very important. Sperm quality is very important. uterine quality and anatomy is very important for a female. And we do see some changes as age increases in the female in terms of the uterus and its ability to implant an embryo. Fortunately, those changes are usually very subtle. And so when a patient in their 40s undergoes treatment with donor egg, oftentimes their success rates are very, very good. But there is a subtle decrease that we have been starting to see in some data that has come out recently that shows just a slight decline in those success rates. And we think that that's probably related to the uterus and its ability to implant the embryo, whether that's related to other medical comorbidities that the patient might develop as age increases, like vascular issues, cholesterol issues affecting the blood supply to the uterus itself. That's possible. And we do see an increased incidence in other structural components like fibroids, adenomyosis. These things can all play a role in the function of the uterus and its ability to implant an embryo.
Great, great. Exactly. That's exactly right. You know, as time goes on, all of us develop more medical related issues, and women who are of reproductive age are no exception, obviously. More fibroids, as you said, which are structural abnormalities inside the uterus that are acquired over time. Endometriosis, as you said, adenomyosis. These are all significant issues that can affect even the exposure to a variety of environmental toxins over time can occur. Let's talk just briefly, I think, about how we determine what a woman's ovarian egg supply looks like. What measures would you take? And we know this happens all the time. Every day we have patients come in and say, I just want to have a general idea of kind of where I am. And you know, I'm now 32, I'm 33, I may not be trying to get pregnant for a year or two. What is it that you look at? How do you determine what somebody's ovarian competence looks like at this point?
I'll generally look at a few different components because we know these are just estimates of the ovarian reserve. None of them are direct counts or direct measures. And so it's helpful to have a few different components to look at so that in aggregate, it gives me a good understanding or a good idea of what that ovarian reserve might look like. The first thing that I like to do is an ultrasound to look at both of the ovaries. Within that ovary itself, there's usually tens of thousands of follicles. Each one has an egg inside, but they're microscopic. We cannot see them. But over time, every month, the ovary recruits a cohort of those follicles to begin to develop. They start to grow, and we can visualize them on the ultrasound. The higher somebody's ovarian reserve, the more of those follicles that get recruited at any given time. And so by doing an ultrasound and counting the follicles that I can visualize, that's called an antral follicle count, or an AFC. That's a very good measure of that patient's ovarian reserve. And again, we see that that number generally decreases over time. The other measure that I like to evaluate is called an anti-Müllerian hormone level, or an AMH level. This is drawn in the blood, and it comes from those exact follicles. So those follicles make and produce this particular hormone. So the higher the ovarian reserve, the more antral follicles that are on the ovary, and the higher the AMH level. So generally with those two components, I can get a very good estimate of what somebody's ovarian reserve is, and I can tell them your reserve is comparable to patients your age, it's above average, or maybe it's a little bit below average for your particular age.
Great points. AMH is has become a very important and household name. This particular hormone, AMH, this particular protein, has become a sort of a household name in women who are trying to conceive or planning to conceive. AMH, what does it measure? What does it not measure? And I think that's the important thing. What are its limitations, I should say?
Yeah. So you're right. It's become very common, and the main reason for that is because it is so easy to measure. You can just get this from any blood sample, so anybody can send this off. So it's a common request for patients and commonly sent by physicians. But then the challenge becomes when somebody gets that information, they often don't necessarily know what to do with it, because to your point, AMH does not necessarily measure somebody's fertility. For patients that are having regular menstrual cycles, they're generally releasing one egg every month. So it doesn't really matter what their ovarian reserve is. It doesn't matter how many eggs are remaining in the ovary if they're actively trying to conceive at that time. They could have a low reserve, average, high reserve. They're going to have the same chance of getting pregnant as anybody else their age, regardless of that particular ovarian reserve. So that's the most important thing to know, that it doesn't predict fertility, whether it's high or whether it's low. It does predict how somebody is going to respond to treatment, if they're doing ovarian stimulation, IVF, if they're doing egg freezing. So that's number one. The second question that patients will often ask when they come, especially with a low AMH level, is, does this mean I'm going to go into menopause early? Am I going to run out of eggs sooner than somebody else? We know that for patients that are a little bit further along their reproductive lifespan in their 40s, once that AMH level becomes undetectable, we see that patient generally goes into menopause an average of 5 years later. What we don't see, or what we don't have great data for yet, is that for patients that present with an AMH at a younger age, how quickly that AMH is going to continue to decline. There's probably two different categories of patients. There's probably one category who maybe they just started out with less eggs from the beginning. Maybe they weren't born with 1 million, maybe they were born with 250,000, and they're on a very predictable decline, just like anybody else their age, but they started with a lower amount. The other category could be patients who are on that accelerated decline. And even though they started out with a normal amount, that number is being reduced faster than it should be. And there's unfortunately not a great way to predict that. And so we don't know how quickly that will decline without continuing to closely follow that patient over time to trend those levels and see how they behave.
Yeah, so excellent points. One thing I tell patients is exactly what you just said, that in any particular cycle, you can't use an AMH level to determine whether you're going to get pregnant or not. It's not a fertility test as much as it is a test of their supply of eggs, as you said. But it does give you some information, and I think you made a very good point when you said that it may reflect maybe two different populations. I think AMH is particularly dangerous to overutilize in younger patients because, as you said, they may have a lot of very good eggs still, but it might have more value in older patients who understand that older patients with low AMHs tend to do worse than older patients with normal AMHs. But the whole concept of what's normal or not normal is very hard to determine, and there's a lot of overlap between what some people consider to be normal levels and abnormal levels. But 100%, it gives you a pretty good idea that somebody's reproductive lifespan may be shortened, but it doesn't tell you about what's happening right now. So I agree with you 100%. What advice would you give to somebody who is, 30 years old, not at this point in time necessarily trying to conceive, but hoping to potentially conceive in the future, or a couple, for example, who are trying to conceive or will be trying to conceive in the near future? What would you tell them to do at age 30 versus 35, for example? What would you tell them to try to assess?
So, it's right about that age when somebody's in their early 30s, where if they're not sure what their family's going to look like in the future, if they haven't really put much thought into it, that's the time to start at least having those initial conversations, have those initial thoughts. And it's a good idea at that point to go see your gynecologist and have that initial conversation with them, or go see a reproductive endocrinologist where we can talk to you about what your fertility options are, different ways that you can build your family based on your age, based on your goals, whether you're single, whether you're in a relationship, whatever that may be. There's many different options in terms of building a family, in terms of preserving your fertility. And getting that education, I think, is a critical piece for many patients. And then they can individualize that and decide what they want to do with that information, again, based on their own individual situation and goals. We often talk to patients, at age 30, 31, 32, if they're not planning to conceive, start building their family within the next few years, that's an optimal time to think about doing fertility preservation, because egg quality is really at its peak at that age. And we know as time goes along, that ovarian reserve is going to continue to decline. So we can really get a maximal yield of good quality eggs around that particular age range. And a lot of my patients that come to me to do fertility preservation, they don't know what that future is going to look like for their family. Sometimes they're not even sure if they want children, but they know they want to keep that option open. And by doing or considering fertility preservation, it's going to give them the best possible chance to build their family, however they might choose to do that in the future.
I just thought of something as we were talking. We said that people shouldn't panic necessarily if their AMH is low, because it may not reflect their true fertility at that time. But there's the opposite situation. And I see many patients who have been told by their doctors, whether it be a primary care doctor or their OBGYN doctor, they've gone to see they've gone to see a OBGYN and say, listen, I'm 35. I really want to have a good idea. How much time do I have left? So an AMH is run and it's a decent level, let's say above 2. And they're told, no worries, don't even worry about it. What would you say to that?
That gets back to some of our prior conversations, that the AMH level, that number of eggs, just does not predict fertility. It's really
Right.
about egg quality. So while that's reassuring that 35-year-old has an AMH of 2, you know, that's a pretty reasonable level, or a pretty average level at that age. And if that patient was telling me that they were about ready to start trying to conceive, I would say that patient has a very good chance of being successful. But if that patient said, I probably will wait until my early 40s before we start to build our family, that's somebody who needs to understand that egg quality is going to decline significantly over the next 5 years. And if that is their plan, they really should seriously consider fertility preservation at that age to help them achieve success later down the road.
Great. Yeah. And the whole impetus for this specific talk is that age is paramount when it comes to egg quality and fertility, not the AMH level. AMH levels can be helpful in the way that you describe, but age is still important. You know, age, it's so important. And I don't want to in any way diminish the value of the man's age in all this, but that's a subject for another talk. This has been very helpful. Thank you. I want to thank Dr. Romanski for bringing us some knowledge here and for trying to clarify some of the very common issues that patients face when they're looking at either future fertility or current fertility. And this concludes another segment of Fertility Speak, Conversations with Experts. And we will see you in a couple of weeks for our next segment. Thank you so much, Dr. Romanski.
Thanks, Dr. Stein. Bye, everybody.